Good morning. Thank you for receiving me and having the patience to listen to a Dutchman talk about his favorite pastime, analytics. And today on healthcare. One of the key issues that I'm going to talk about is use cases of our customers today, to give you kind of an illustration, especially this morning. This afternoon I'll go a bit more in some of the background as well. Not sure, has anyone in this audience heard about IBM Watson? One, okay. I'm not going to talk about Watson today. For those of you that don't know it, IBM Watson is a system developed by IBM to work with natural language. It has beaten 2 of the Jeopardy champions in the US on television, and it's now going to med school. And the idea is that it will actually collect all information that is published on medical knowledge to help doctors diagnose and better treat patients, because it's physically impossible to keep up with what is being published in medical science. Watson actually has the ability to read millions and millions of pages a day and actually make sense of that and bring it together and then generate recommendations for doctors based on the input that they give the system. If you're interested in that, I'm happy to talk to that. I'll be here the whole day. And there's also a lot of information and videos about where he is now in his medical training on YouTube and other places. So if you're interested in that, please come to me. I will be talking about things that you can use today or tomorrow, examples that we did. And the key there is all about outcomes. The key in healthcare is how can we improve the outcomes of our service delivery? How can we actually make sure that and what are those outcomes? Well, it might be more satisfied patients, but also maybe better outcomes in that there are fewer readmissions. One of the key issues, I think, also here in the UK and in the US, but it's coming up in other areas as well as a key outcome. Don't actually let people go home too soon. Look at your readmission rates as well, things like that. So, and what I'm going to talk about is how predictive analytics can help there. And it's actually about how can we go from a doctor-patient, one-on-one relationship, and how can we actually take the information that the doctor uses with his knowledge and his risk assessments that he does, and make that available to others as well in the organization. I had an interesting conversation this morning. Right, every doctor does risk assessment all the time. Right, he always assesses risks all the time. The problem is that maybe in current education systems and with changes in education systems, the risk assessment teaching is changing, and the other problem is that we are not consistent in our risk assessment. Each individual doctor will look at a patient and have a different risk assessment. So how can we be more consistent in actually judging those risks about patients? And we need to go to a more patient-centric care system. Because the patient is not alone, we also have, we call it payers in general, because there's of course different systems across the world. But we have to work with other providers, other doctors. We have to work. The patient needs to be in a centric, needs to be at the center. And then we need to treat them, but not all treatments work for all patients. Right? This is an older research about the ineffectiveness of drugs. It was in research from 2001. Right, 38% of antidepressants were ineffective. So basically, it means that how can we actually make sure that the treatment that we do for patients is more effective for the individual patient? And that means that we need to go into a new era where we're used to rely on scientific research and then digest that information, build our own kind of decision models, and then put it into practice, to more innovative, looking at other ways of collecting data. And there's a lot of data out there, especially in healthcare. There's a lot of patient records. There's a lot of notes about the patients. There's a lot of information from all kinds of sensors. There's information from MRI scans. There's information from blood samples. Loads of information. How can we actually use that information to start to identify new ways and good ways of treating it. And oh, by the way, in all those data hidden is all the knowledge of the doctors that are working in a hospital. Because it's basically a kind of an administration of the decisions made by doctors. And you can evaluate those, and you can learn from your mistakes in the past and try to improve to the future. Nice was just said about buildings as well, right? If we learn from our mistakes, and that's how people learn, right? That's how our brain works as well. It's basically, we learn from our mistakes, and we actually do that. And then we want to actually start differentiating and breaking away, and by offering people the next best action to take, right? Which is what Watson is doing, offering the next best action based on medical knowledge and medical research, but also a next best action maybe for a nurse, or a next best action for an ambulance driver. And I'll give you some examples there in a minute. So how can you use analytics? On 3 different levels. In decision making, there's kind of 3 levels of decisions. We make strategic decisions, which are usually for the longer term. We make tactical decisions, which are short, medium term, and usually directed on how we organize or approach a certain problem. And we need to run the business operationally. So what can predictive analytics? Right, we all look at kind of reports with how we're doing. Sometimes it's called key performance indicators. Some people don't like that term, but I'll just use it. But we can add those with key performance predictors, right? One of the things with a key performance indicator is it's very nice to look at what has been the average length of stay of my patients in my hospital over the last 6 months. It's interesting to know, but you can't change it. Maybe a key performance predictor is better and say, what is the average amount of days that people are that are in my hospital at the moment are going to stay? And then I can actually use that on a tactical level as well, because if I can predict for each individual patient pretty accurately how long they're going to stay in the hospital, I can actually tactically organize and staff my nursing and arrange my nurse staffing. And then on the operational level, I might actually look at, hey, this patient actually now has a prediction that is much longer than I would expect as a doctor, right? What is causing this? What do I need to do with this patient to maybe shorten that? So I can actually get a key performance predictor from the top down to make decisions on a strategic level, on a tactical level, and then I can actually use it in some other, a great example that I just was part of in the Netherlands, a project that we did on the tactical level is about undernourishment. How can we identify undernourishment is a problem that can lead to all kinds of complications. And what they built there is a model that really gave them the option to early identify the risk of undernourishment for all patients based on the blood samples and some other characteristics, which basically means that if you can then put in feeding, how do you call it, food supplements earlier in the process, if you can identify it earlier, you can minimize the number of complications, but you can also shorten, on average, the length of stay in a hospital by 2 days, because you can actually look at an early one. That's what predictive analytics does. It helps you improve your decisions by not looking only backwards, but actually giving you kind of an estimate or an expectation that you can take an action to change. One of the big issues, I think here as well, in the US as well, right, is readmission rates. How likely is it that this person is going to be readmitted within 6 months if I would let him go now, right? If that risk is too high, you need to look into it and say, okay, what do I need to do to change that risk? Or how can I change that risk by the next best action, maybe calling in community care or other care around them to minimize that risk and organize that caregiving in the home. So what's the predictive advantage? Traditionally, we look at now, right? And with conventional analytics, and we try to look at measuring what have we done yesterday, what have we done last month, last quarter. It does give insight, but it doesn't go further than this point of time. And it kind of is an aggregate of data. With predictive analytics, we use all kinds of algorithms, from traditional statistical algorithms to modern machine learning algorithms, artificial intelligence, to look at all kinds of patterns, and we use that to get deeper insights, right? The example that I just gave about feeding supplements, the undernourishment. Another example is looking at risks of patients falling. Can I identify risks that increase the likelihood that a patient will fall if they go to the toilet or if they go to under a shower or whatever, so that I can actually focus my attention in there. So you learn from your historical data, you learn from the patterns in the past, and you create predictive models that you then can apply to your current set of data, to your current patients. And then you bring it into the organization, so you need to deploy it. Now, one of the things could be to change protocols to make sure that, right, to do it, or you might actually do it integrating it into the system. If you have a full risk prediction, right, it doesn't make sense to have everybody go through all kinds of rules all the time. No, you might actually just display it in the on the screen at the nurse. This patient has a high fall risk. So when you take care of him, make sure that you keep into account that he has a high risk of falling when he goes alone into the shower. And it might also actually be a good input overall for the manager of a department to know that if I have a lot of people that have a high fall risk, I need additional care, I may need additional resources for the coming period of time. So you leverage your current and historic data, you make predictions about your current cases, and you embed it into your decision making. You give the information to the right people at the right time, right? To make sure that they can leverage that in their prediction making. So what the idea is to go from sense and respond, which is kind of what we've been doing, to predicting and acting and preventing, right? One of the things that we're doing a lot is what we call predictive maintenance, right? Predicting the likelihood that a medical equipment is going to fail while you need it for treatment. If you can predict that, then you can actually do maintenance before it fails, so that you don't have a disruption of operations. That is coming more and more built into medical equipment. We're talking to several medical equipment manufacturers, right, like MRI scanners and things like that. But it can also be used on smaller things, on smaller issues in the estates, right? The likelihood that an elevator is going to fail, based on usage patterns and all kinds of other things, you can actually pretty likely predict that there's going to be a problem. If an elevator fails, it has an influence on the traffic flow in the hospital. The traffic flow in the hospital has an influence on waiting times. The waiting times have an influence on patient satisfaction. But it also has an influence on how patients are treating patient satisfaction, and patients' experience have an influence on how they're treating your nurses, your employees, which has an influence on the stress levels. So that there's a lot of connections from just very simple, and I like the story about the estates that you brought. Just an elevator that is failing can cause a lot of absenteeism because people get dissatisfied and get kind of put the pressure on the nurses and the doctors. Right? Some examples. And for this conference, I've tried to minimize the number of American examples, and I thought, let's look in Europe. We do have examples in the UK as well, only they're not publicly available. So this is from Antwerp, Belgium. A key issue in a very rare disease for children, and the earlier you detect it, the better you can treat it. Now, traditionally, there were all kinds of indicators from medical science that you could kind of go through and look at it, but there was a high false positive rate, right? So children were assigned to probably having the illness, but they didn't. But they then had to go through a lot of tests to actually determine whether they had it or not, and a false negative rate. They were missing a lot of children that had the illness. So combining those research rules with the data that they had from the results, with different tests, with input from all kinds of blood tests and all kinds of other lab tests, we were able to actually increase the specificity and the reliability of that prediction. It's not perfect yet, but it's a first step. And the key with these models is they're not built to be there for the rest of time. They're built to improve all the time, to learn from new data that you get, and to learn from your mistakes, but also learn from what goes well. So this is an example where we took knowledge and rules and decision-making rules from medical science and put it together with data from the hospital to actually improve the diagnosis of a rare disease. Spain. in mental science. How can we basically predict the factors that cause good treatment, good reception of treatment with people in eating disorders? And how can we actually then use that to manage our treatment and better do it? Now, one of the key things is that they basically were, by the solution, were able to get much easier data together so that they had a better insight on what was happening in their patient base anyway. But there were some very specific things that they found that they weren't aware of. How important the expectations of the patients were. Right? The expectation of the treatment is very important in how the treatment will work. They found some new lines of research, of course, but they also, and that's the key to it, if you can get your diagnosis and your treatment up front and you start to organize it better, you can also get efficiency gains, right? In here they have 5 to 10% improvement of efficiency and effectiveness. So basically, if you improve the quality of your care, you can save money, right? Quality makes money, quality doesn't cost money. It's basically, and that's going to be my story all day. If you take the right approach and kind of start looking at what you're doing. Metrospinal in Australia is about talking to your patients, listening to your patients, using survey research and combining that with other data to better describe and give people the possibility to investigate pain and to identify pain. Not just using checklists and all kinds of other stuff, and is this a 5 or a 10? No, maybe even using open-ended questions, right? Using text. A lot of our information in medical environments is in text, is unstructured. So you need to also take it into account. And then you can ask a patient, how would you describe your pain, right? Give it in your own words instead of trying to fill out all kinds of checklists. Basically, they reduce their whole cost of measuring the pain and managing it, but also their follow-up questionnaire rate improved, right? Because of the way they were doing their questionnaire. So they got much more data and they got much more involvement of their patients. And actually, it made it easier for physicians to actually diagnose and treat pain. There are several user stories also available on our stand. These are also user stories that are available on our website if you want to have more details. In Japan, liver disease, right? How can I actually identify what are the necessary treatments for a liver disease, for a virus infection, and minimize the number of steps that I need to do in treatment, because treatment is intrusive to the patient and it costs money. So basically they started to build up, based on, for each individual patient, to develop models that could actually help them with recommendations how best to treat each individual patient. They improved the removal of the virus by 43%, but they also reduced the number of steps in the treatment process, so that basically, right, patients didn't have to suffer those painful treatments, those painful tests, and things like that. So it works both ways. This is from the Netherlands. Where do I treat patients, right? If I can identify a heart attack soon, and if I have a model that predicts based on some very simple diagnostics to somebody in the ambulance, the first responder, that this is very probably a heart attack, they can also already start the treatment. That will prevent complications, that will increase the survival rate, and it will also shorten the stay of people in hospital. So in the Netherlands, what they did is basically they built a model that first responders can use to get an idea, is this a likely heart attack? Then we follow up the protocol for treating a heart attack straight away, so that when they come into hospital, half of the doctor's work had already been done. And the patient was the better for it.
I'd like to allow some time.
Yeah, this is my last one. Last one, cancer in Italy, colon cancer. Again, how can I individualize cancer treatment to my patients, making sure that I only do those steps that are relevant for this patient based on the data and the knowledge that is hidden in all the data that I have in my hospital. That's what I did in Italy. Based on the characteristics of the patients, the measurements, all the data. They can create personalized plans based on what is likely to work best for this patient. Unnecessary treatment, again, and they estimate that they actually reduced it by 60%. Right? 60% of what they were doing was basically unnecessary. Maybe some were relevant for some patients and some for other patients, but now, since every patient was treated the same, now they're making it individualized, so they reduced it by 60%. Personalized treatment was to increase, but also, again, better care, improved hospital performance. Right? Reducing treatments save money. Reducing treatment reduces pressure on your staff. Maybe increases the possibility to maybe spend longer with a single patient to increase patient satisfaction, or less intrusive treatment improves patient satisfaction. All kinds of areas that you may want. So, if you want to know more, I'll be back again after lunch with a more extensive talk. Of course, there's room for questions, and then our stand, we have some user stories we brought and white papers we brought with us, but there's much more of interest if you want to know more. And like I said, I'll be around for today.
Yeah, thank you very much.